This is a general disclaimer. Redlands Community College attempts to have the most accurate and up-to-date information listed in its content and delivery. However, your education is your responsibility. Redlands Community College or Roy Smith makes no guarantee in the accuracy of this information in this video and accepts no liability for the informational video. The information expressed is strictly the opinion of the author and the presenter, which is listed in the reference near the end of the video. This information is designed to supplement your own education or initial education and should not be used to replace any current academic program you're enrolled in. View the information and content at your own risk. Thank you.
This is going to be Chapter 9, Disorders of Ventilation. On completion of this chapter, you'll be able to understand the two types of respiratory failure, how Type 2 respiratory failure exhibits more with carbon dioxide retention, whereas Type 1 does not. That chronic obstructive pulmonary disease is the most common of Type 2 respiratory failures, and how to direct Type 2 respiratory failure assessment and treatment toward finding and improving airflow, effort of breathing, and surface area for diffusion. Chief concern, Type 2 respiratory failure, distinguished by an added feature of carbon dioxide retention, tends to result from ventilatory problems, and the most common cause is chronic obstructive pulmonary disease, or COPD. Pathophysiology of Type 2 respiratory failure, hypercarbia. So anybody that have a high amount of CO2 could fit into this category. Now the COPDers have that because they retain CO2 because of the damage or the inability to ventilate from whatever cause. Now most of them have a combination of diseases, whether it be asthma, or chronic bronchitis or emphysema, any two combinations of those, or any of those two, for more than 6 months, and they have the diagnosis of COPD. Retention of carbon dioxide is essential, caused by a reduction of effort of breathing, increased resistance to airflow, or decrease in lung surface area for diffusion. COPD diseases. We have bronchial wheezing, and we come up with the term of asthmatic. So in asthmatic, there are several causes of this. This stands for an acronym. Asthma being the top one, stands for A. Stasis, stasis from blood, from a PE. Toxins, gases, poisons, damage to the endothelial lining of the lungs. Heart-related, and this would be cardiogenic. That would be H. Mechanical, M, stands for mechanical obstruction, and that would be from foreign body, like a Hot Wheel car or a piece of steak. Allergens and anaphylaxis can give us problems as well. Trauma of the respiratory tree causes swelling, secondary inflammation. Infections, inflammatory response. So if someone's infected with a bacteria that's in there and the bacteria is setting up shop, it will cause inflammation. And then chronic respiratory diseases is the last one here, emphysema and COPD, chronic bronchitis, combinations. So bronchitis. Bronchitis is an inflammation of the bronchi, generally due to a viral infection. Chronic bronchitis is inflammation of the bronchi, leading to a productive cough for 3 months during 2 consecutive years. Okay, so you get chronic cough and chronic inflammation of your airways for 3 months, you have chronic bronchitis. Now you place any other disease process, like let's say asthma or emphysema, in combination with that, and now you have COPD. Emphysema is obstruction to the airflow that leads to hyperinflation of the alveolus. And then cor pulmonale, or essentially pulmonary artery hypertension, cumulative over the years of a gradual respiratory failure of the right side of the heart. For some, we have pulmonary hypertension or increased blood pressure within the pulmonary vascular beds, and this would be because the heart's trying to compensate for the low amount of oxygen. So it'll increase the pressure on that by squeezing it down, but that's more damaging. That causes heart failure. The muscle is responsive. We back up pressure in the heart. Let's go ahead and just draw this out for a second. We back up pressure in the heart from the pulmonary artery, and then the right side gets bigger. At some point, the right side would go into failure. Tobacco smoke. Risk of developing chronic bronchitis and or emphysema by 10-fold and triples the risk of dying from heart disease. So all of these are additions to and possibilities of the tobacco smoke, the chronic bronchitis, the asthma, the emphysema, any combination of those. If you had something acute happen like a PE, All of these should be considered when looking at the pulmonary patient. Okay, asthma. Asthma is its own thing. It's an obstructive respiratory disease manifested by airway hyperirritability, so it really is irritable. It's really responsive. A reversible bronchospasm and inflammation. The epidemiology of this most common childhood disease, affecting over 4.8 million children in the United States alone, and an estimated 5 to 10% of adults in the population in the United States has asthma, and that percentage is increasing every year. The number of new cases of asthma has increased by 40% in the last 10 years. Atopy means genetic. It can be genetic, but not always. Genetic is an IgE antibody-induced hypersensitivity to the allergens, and this is found in approximately 50% of the population. So we get a 50-50 shot of the people that have asthma if they are atopy or not, or have IgE antibody trigger, which would mean they are an allergy trigger. Acute exacerbation of the asthma. Hyperresponsiveness, a tendency of the bronchioles to narrow or bronchoconstrict with the smallest of stimuli. Acute exacerbation of asthma can be kind of biphasic. So whenever we get a trigger, whatever that trigger might be, it could be psychosocial, it could be from allergens, it could be from irritation in the air, whatever the trigger that caused it, it's a bronchospasm. And it's hyper-responsive. So anything that irritates it, bam, and it bronchoconstricts. Long-term effects on this: smooth muscle of the bronchi start to hypertrophy. The submucosal edema occurs, as well as deposits of collagen underneath the basement membranes. Now this hampers with diffusion, so this is progressively going to get worse. They combine to remodel the airway. It increases the air trapping as it hyperexpands the alveoli, which start to break down, leading to emphysema. So this kind of exacerbates the next disease, which is probably emphysema. Hyperinflation of the lungs in the thoracic cavity cause the patient to become barrel-chested. Asthma or emphysema, many common features, cause of shortness of breath, wheezing, and coughing, occurs as a result to an exposure to a trigger such as cold air, infections, exercise, and so on. The difference is how we're going to identify. Age is a primary one. Asthma affects patients of all ages, and then whenever we look at emphysema, it's primarily a disease of the old. Now, not always, not 100% of the time. And then permanency. And an example of this, in asthma, it's reversible. Even if they have status asthmaticus, it's the asthma attack or the bronchial constriction is reversible. In emphysema, you have permanent lung damage. So that's how we identify the differences between asthma and emphysema. Classifications of asthma, we have quite a few of them here. We have mild. So we identify these by how many times that they have an asthma attack, essentially. So on mild, let's get something, let me see a little bit better. Mild intermittent asthma, brief exacerbations. They're infrequent whenever they occur, less than twice per week. Asymptomatic between exacerbations or flare-ups. Nocturnal symptoms about once a month or less, where the asthma attack wakes you up and you have to have your rescue inhaler. Mild persistent asthma. Symptomatic 3 to 6 times a week. Now we increase the frequency. Exacerbations may impair activity. Nocturnal symptoms several times a month. Moderate persistent asthma. Daily occurrences of symptoms. Daily use of rescue inhaler. Exacerbations may impair activity and increase frequency of nocturnal attacks weekly. Severe persistent asthma. Continuous symptoms of cough, wheezing, and chest tightness. Frequent, almost daily, nighttime symptoms. Key, limited physical activity secondary to asthma. And then this would be severe. So whenever we're looking at this. So all of these is how the pulmonologists identify or classify asthma. Is it mild? Is it mildly intermittent? Is it mildly persistent? Is it moderately persistent? Or is it severe? Respiratory acidosis. Neuromuscular diseases can give us, these are all causes of acute respiratory acidosis. One of the things that we get from neuromuscular diseases is the inability to breathe right, or paralysis. So Guillain-Barré syndrome is one of those. Muscular dystrophy will cause a decreased respiratory, and eventually they may have to be actually on a vent. Amyotrophic lateral sclerosis, or Lou Gehrig's disease, another horrible degrading neuromuscular disease. And then myasthenia gravis. Myasthenia gravis, autoimmune, attacks your parasympathetic nervous system, so you lose some of your control. Airway obstruction diseases are like asthma, chronic bronchitis, emphysema, obesity, hypoventilation syndrome, or Pickwickian syndrome. Weight of the chest is too much, so we don't get ventilated like we should. Hypoxic drive, persistent elevated carbon dioxide levels, and to the point to where your current body runs off of CO2, or as CO2 elevates, it makes your respirations increase. Well, in the person with a hypoxic drive, they've seen CO2 too much. So, in doing so, they have switched to their backup system, which is oxygen. Tends to blunt sensitivity of chemoreceptors to elevated carbon dioxide in the blood. Body relies on low oxygen levels or hypoxia to stimulate breathing. Any patient suspected of being hypoxic should not be deprived from oxygen. So there's a wives' tale that goes along with this, that I'll knock out their respiratory drive, then ventilate for them. In a hypoxic drive, if you think the patient is still hypoxic and they can't manage to ventilate themselves, assist them. Use oxygen. History. Considerations, we should do a sample history on every one of these individuals. We should see some diseases in their past. Signs and symptoms, allergies, medication, pertinent past medical history, and last oral intake, and events leading to the emergency. There's a mnemonic for respiratory stuff called Happy Socks. History of pulmonary disease. A stands for activity of onset. Pain upon inspiration. Infections. Are they a smoker? Orthopnea. Do they have a cough? Is it productive? Are they producing any sputum? And then that little acronym, the mnemonic, Happy Socks, helps you kind of ask the right questions. Procedure, establish the cause of the patient's shortness of breath. So history is important here, especially in medical illnesses. If it looks like a duck, walks like a duck, and talks like a duck, there's a good chance it's a duck. Ample allergies can trigger the asthma, can be grossly categorized due to their environment, food, or drugs. And then peak flow meters, not all of us have these on the truck, but peak flow meters are awesome. They can tell us very quickly off of 3 ventilations if there's been any improvement by opening them up. Now, we're going to talk about drugs here in just a little while, but for the most part, people use albuterol too much. If they have a shortness of breath, the first thing some paramedics will do will throw them on an albuterol treatment. Be sure that you have clinical evidence that they are having a bronchospasm. That is what the albuterol is for. Okay, so history leading to a high index of suspicion of asthma. So symptomatic approach, reoccurrent wheezing, persistent cough, awoke with a cough, recurring shortness of breath, recurrent chest tightness. All of these right here are very simply going to be, they have the right symptoms. Generators, did exercise cause this? Recent viral infection, contact with animals, house dust mites. All of these are allergy related or environment related or exposure related, like I exposed myself to cold weather and exercise and I had a bronchospasm. Exposure to unfamiliar mattresses, pillows, upholstery and furniture, mold, smoke, pollen, changes in weather, and then airborne chemicals. All of these would be, this would be the generators of the actual bronchospasm, and this up here would be a symptomatic approach. So if they have these symptoms frequently, it would increase your suspicion. Examination, consider the symptoms. Example of this is a degree of distress. So narcosis occurs when a drug anesthetizes the brain and induces a state of impaired consciousness ranging from stupor to coma. So whenever we're looking on the examination, looking on the symptoms, we need to gauge how short of breath that they actually are. Patients in respiratory distress rarely lie supine. That's because they need all the assistance of their accessory muscles. Speech and word clusters, whenever we look at that. Choppy bursts of words, spitting out only one-word sentences. All of that would say that they are air hungry or air starved. Nasal flaring. Breathing, open mouth breathing, pursed lips. Pursed lips occurs from the physiological response of the body to the alveolar sacs wanting to trap air, emphysema. The pursed lips essentially give us the ability to increase our own PEEP, which open up the alveolar sacs more. So if you see someone that's pursing their lips all the time on exhalation, there's a good chance that they have emphysema. Breath sounds, how much air are they actually moving, and in that, are they wheezing on inspiration and expiration? This progressively gets worse. We should hear wheezing first on expiration, but as the bronchospasm gets worse, not only can they not get the air out, but they can't get it in either. Persistent non-productive cough may be indicative of asthma, often occurs at night. Vital signs, patient with difficulty breathing will pretty much be hyperdynamic due to adrenaline tachycardia. Diagnostic examination, we should look, if we're looking at capnography, we'll talk about all these respiratory sinus arrhythmia, and the reason being, the more that they're breathing, the more irregular their heart rate is. And that's because as the interthoracic pressure increases, it slows down the heart. 12-lead EKG, we might see things like cor pulmonale, which is a P wave that is greater than 2.5 millimeters. I would say right atrial enlargement, which if the right ventricle is getting beat up, I'll assure you the right atria is as well. And then capnography, if they're having a bronchospasm, instead of a nice plateau, this is a normal end-tidal CO2. And please refer back to a capnography lecture for this. But instead of a nice normal plateau with our number coming from this point, what we're going to see is a nice slow progression. I'm trapping air. It's going to look like a shark fin. So this is clinical indication as well. We'll be talking about capnography. Assessment. Critical clinical decision or the degree of respiratory distress must be addressed. So what kind of respiratory distress are they in? Are they going into respiratory failure, or are they near respiratory arrest? Need to get ahead of the physiology that's present. Division between distress and failure is permissive on the patient's level of consciousness. So if they look like that they're in respiratory distress and they start losing their level of consciousness, or their level of consciousness starts to deteriorate, then they're probably going into respiratory failure. As far as treatment goes, procedure on this, we start off with ABCs. The decision, risk versus benefit on this, to intubate. Now, if they have long-term COPD, if we intubate them, they may never get off the tube. So I always try to ask my patients, have you ever been intubated before? And do you want me to intubate you today? Now, if you do not have the ability to facilitate an intubation, this may be difficult. You'll have to wait until their LOC is decreased enough to facilitate that intubation on your own. But if you have things like etomidate, if you have things like a rapid sequence in your protocols, please consider that. And that's always risk versus benefit. If I do this procedure on them, is it going to benefit the patient more than the actual risks? Their quality of their breathing, their ventilation. Continuous positive airway pressure is controversial. However, we have seen from evidence-based medicine that the CPAP increases the amount of oxygen so that they can get more oxygen in a smaller air sample, especially if you increase the FiO2. Oxygen therapy, one more thing on the CPAP, they have to have their own respiratory drive. If they're going into respiratory drive failure, you may have to assist their ventilations. Oxygen therapy is always paramount in that, especially if their SATs are low. Please remember back whenever we were talking about in the previous chapter on the oxygen hemoglobin dissociation curve. We pretty much stick with short-acting beta-2 agonists and pathomimetics, things like albuterol. Atrovent's an anticholinergic, but it does some of the same thing. This would be the Atrovent. And that's also because of their peanut allergies. The short-acting beta agonists are things like albuterol. And in the albuterol, level albuterol or Xopenex can be utilized as well. The Xopenex is very expensive, so I wouldn't expect it to be hitting the streets anytime soon. And then anti-inflammatory medicines. The number one of choice, we see people on prednisone all the time, but the one that we use the most in EMS is going to be Solumental. So depending on your protocol, 2.5 milligrams, 2.5, Atrovent 0.5. And what these two do, you have the sympathetic nervous system and the parasympathetic nervous system running things autonomically. The bronchospasm was caused by an increase in parasympathetic tone. So what we do is we give the albuterol. It is a beta-2 selective, we still get a little beta-1 response though, and increase the sympathetic tone to dilate out the bronchial tubes. And if, generally speaking, some protocols may have this up front, but if the Atrovent is given on round 2 with another 2.5, it still sends a signal of let's increase the sympathetic tone, but now let's depress the parasympathetic tone. Solumedrol is pretty much for 4 hours down the road. It decreases inflammation in the cellular compartment, acting as a steroid. Treatment continued, aerosolized medication delivery methods, and this is B by meter dose inhaler. Spacers are important, especially if they have low respiratory trigger, so to speak. So what the spacers allow you to do is meter or aerosolize the dose prior to the inhalation of the patient, so they get they don't have to move near as much air to get the full dose of medication. Small volume nebulizers takes a small volume of solution that creates a medical aerosolized via nebulization. Now these are the ones that we mostly use, or the nebulized version of them. We put our medicine in there, it aerosolizes the content, and we just allow the patient to work on it. There's also mucokinetic drugs, things like dilutants, that help liquefy viscous respiratory secretions. Humidifiers is an example of this. Also, there are medications like Mucinex that will help work as an expectorant. So the drug loosens the mucus to help promote coughing and perform a better pulmonary toilet to get all of that stuff out so that we can move air across those airways a little bit better. Evaluation. Asthma is a chronic disease with acute exacerbations. So status asthmaticus is essentially typically the accumulation of days or even weeks of unremitted asthma. So we get sudden onset from this. Rare form of asthma in which the patient rapidly deteriorates into respiratory arrest despite aggressive medical treatment. Physical examination, mental status, their chest, their breath sounds, heartbeat. Kussmaul sign, rapid, fast breathing, trying to get air in any form or fashion, and increased jugular venous distension because of increased interthoracic pressure. Now, all of these, status asthmaticus is essentially one asthma attack after another, after another, after another. You need to get aggressive. Things like the use of epinephrine. Generally speaking, we're allowed to give beta-2 agonists, but whenever we need to pull the clinical trigger on, say, something with a bigger punch, like epinephrine, the epinephrine is generally a call medical control or a line medical control option. Magnesium sulfate might be considered as well, and there's mixed results on this and mixed data on this for the use of magnesium sulfate. Magnesium sulfate would cause a smooth muscle relaxation. The bronchial tubes are smooth muscle, so we have to do assessments quite vigorously if we're utilizing magnesium sulfate. As deep tendon reflexes go away, one of the next things that can go away is our diaphragm. So we might actually impose more problems than we actually have tried to solve. So again, risk versus benefit. Evaluation continued, asthma treatment, small volume nebulizers, intubation, administer respiratory medications, perennial adrenergics like epinephrine. Terbutaline is also in here. Most of the doctors in our region has kind of got away with breathine or terbutaline because of its massive beta-1 properties. If they're older folks with asthma, we can definitely infarct them by the use of things like terbutaline. Intravenous anticholinergics like atropine have also been considered as well. Most of them give it via nebulization and Atrovent on the anticholinergic side. And then magnesium, given either intravenously or through nebulization, have been considered as well. Heliox is fairly a new thing. Breathing gas composed of helium and oxygen, used because the helium molecules are smaller than the nitrogen molecules, and it is thought that they have the ability to slide past the narrow bronchioles with the oxygen. So what the heliox does is it oxygenates better until we can get those airways open. Disposition, patient with status asthmaticus, unresponsive to standard therapies, may need inhaled anesthetics to actually facilitate the opening of these airways. Only administered in operating room or intensive care unit. Once bronchospasm is controlled, many are extubated as little as 12 hours later, but again, they're having one asthma attack after another after another. You have to get ahead of whatever triggered them and slow down the hypersensitivity of the cellular environment. Conclusion, this chapter reviewed disorders of ventilation, and this is a type 2 respiratory failure. Ventilation and oxygenation are two separate physiological processes. Both need to be addressed whenever looking at your patient. References for this are taken from Professional Paramedic Volume 2 Medical Emergencies, Maternal Health and Pediatrics of Del Mar Learning. And if you have any questions, feel free to contact me. My name is Roy Smith, roy.smith@redlandscc.edu or 405-219-7613. Thank you.